are we so dumb? We have done almost, 25 years, 25% of our life we have spent in a medical college. It is almost equivalent to a killer's walkout time from a jail for a murder. So much of time we have spent, we are definitely superior. We are made of superior stuff. That is the problem. We are always flying in air. So that is the very reason fundamentals get ignored, neglected, disregarded, and taken for granted. For example, you may not be sure whether your assistant has, reserved even blood for the next day's surgery. So here, checklist comes as a savior. It comes like a knight in a shining armor. It basically covers for our ignorance, our absent-mindedness, forgetfulness, etc. Any organized sector in the world, for that matter, runs on a checklist. For example, even today's meeting, today's conference, for this, Dr. Srivastava must have had a checklist which he has followed. It's unfortunate, but I have to say that hospital is a disaster zone. And the venue is the operation theatre, which accounts for 50% of the complications that happen in this particular complex are preventable. And 1 million deaths in a year are because of complications of surgery, and in this 50% are preventable. So why do these occur? This is not me, this is statistics. Is it failure of expertise? Is it failure of expensive drugs? Is it failure of expensive devices and machines? No, friends, it's just oversight, overconfidence, and lack of communication. Surgery is like an orchestra. To save one life, scores of people must perform 1,000 things correctly and simultaneously. Right from the time the patient enters the hospital gate till he leaves. Things have to fall in place. So how did this originate in my mind? This was basically coincidental. From the time I started my practice, I had these experiences in and day out, where not because of execution, but because of very surprising, silly reasons, I used to end up in complications. This was very simple and basic, and just an extra effort, giving attention to these issues would have probably prevented a complication. And this is the same time, Gawande came out with this book. So it was an overlap of my experiences and this book, which gradually helped in forming this particular checklist. It was basically for my own comfort to prevent complications which were happening in, intraoperatively as well as postoperatively, that we designed this particular checklist. They do not teach you how to operate a complex case of scoliosis. Instead, they provide reminders of the most important and critical steps, the ones that even the highly skilled surgeons who routinely do such cases would miss. This is just paraphrasing Gawande. The triumph of WHO checklist is well established. Reduction in infection rate as well as mortality rate by 50% has been noticed. So why reinvent this wheel? But it's not, we are not reinventing a wheel, but basically we are giving a spinal spin to this particular wheel, because spinal surgery lies at the zenith of permutations and combinations. There are different regions, there are different junctions, there is left and right. When it comes to approach, it is a 360-degree surgery. I mean, it could be anywhere from those 360-degree angles, any angle from in that 360-degree. And again, there are so many permutations and combinations within surgery. Fuse or not to fuse, decompress, decompress or decompress plus fuse. We need a plethora of substitutes like bone graft, bone cement, etc. And when it comes to implants and instruments, there is again a plethora of things which may or may not use, and that all has to be on table, and absence of one particular issue can make a big difference in the patient's outcome. So there is a lot of crowding of thought here. Now, surgery is not just cutting. Surgery has three phases: the pre-operative phase, the intraoperative phase, and the post-operative phase. If you see, the pre-operative phase is the most important phase because this is the phase of planning. So all battles are first won in the mind. And post-operative phase is much more important because this is the time we notice complications. So this is what the checklist consists of. It says a pre-operative band, a intraoperative band, and a post-operative band. I cannot go through the entire details, but I can just give an example. For example, there is a bailout surgical plan in the pre-operative checklist. If you're not thought about it, you will not have bailout implants on table. And post-operatively, if you're not suggested to the patient that certain complications, for example, a watery discharge from your wound can happen post-operatively, and you should immediately report to us. Patient might ignore it and come back to you with blown out meningitis. So this comprehensive 37 point checklist did make a difference when we compared one year against the other when we used it, against a year when we didn't use it, and there was significant difference in the complications, and most of them were not related. These complications were related to execution only and not planning. Following a checklist is not new to us. We always follow a pre-operative checklist. We have a checklist in response to a neuromonitoring, in response to a signal in neuromonitoring, warning signal in neuromonitoring. So why a spine surgery checklist suits our milieu? This is because there is a lot of stigma associated with spine surgery. We carry the infamous tag of failed back syndrome. The kind of complications that we face are devastating, and the costs of managing complications almost 1 to 1.5 of the primary index surgery. Again, we deal with high volume of surgeries. We have this untrained OT nurses and boys in our atmosphere, in our environment, and there is limited and bizarre distribution of resources that we have. For example, a neuromonitoring machine in the city of Bombay. There are just 3 or 4 of them floating in the city of Bombay. And we have floating inventory. We don't have storage of inventory in our hospitals. These are basically order on demand. And our fellows are here today and they are somewhere else next day. So that continuity of communication gets lost. And we have a very poor and disconnected surgeon GP algorithm. I'll take another minute. So this checklist was acknowledged worldwide, and we got this award for promoting safety in spine surgery. This was in 2021 when we were doing this on paper, and then we went paperless. This is a web-based checklist which our unit follows, and the very next year this got another award by the same safety in spine surgery project. It's well published. So checklist is the application of knowledge we have consistently, correctly, and reliably. It is making things happen correctly. It shows that each problem has steps of solving and shows that each step is important. Shows that the more you repeat it, the more you master it. It allows surgeons to concentrate on non-mundane stuff. It offers the possibility of verifications. It establishes effective teamwork, that is clear distribution of responsibilities. It fosters effective usage of resources and skills. It provides customer satisfaction. So in all, it is an efficient, reliable, and cost-effective method of preventing complications. It's subspecialty specific to spine. It stimulates discussion within the team. It reduces miscommunication within the team. There is no compulsion to use it. This is helping us in our practice, and you can always customize this to your milieu. Thank you.